Okay, so we're going to move on to this part. Everybody hopefully can see that now. So I'm an outpatient speech therapist at KU, and I was trying to figure out today how many years I've been doing this, which is always a scary thing to put together. But I figured out I have been doing this for 28 years. And I thought, gosh, I've been doing it longer than some of my patients are old, which is kind of amazing because I see a wide range of patients. And many times, the title today was, what are you talking about? Well, sometimes people say, well, I'm here for speech therapy, but I can talk just fine. And yeah, we're looking at other things that rather than just talking. We'll talk about that a little bit today because we'll focus on aphasia, but we'll also talk about some of the other roles that after a stroke or other neurological events, people may need a speech therapist. So you guys feel free to join in at any time. You're welcome to interrupt me, chime in if you have questions or comments. I'm fine with that. So we are going to start with what speech therapy looks like, just because even though we're focusing today on aphasia, I wanted you to know maybe you didn't see a speech therapist when you were an inpatient and kind of where that looks like, or what things might have been looked at as a speech therapist may have been involved in someone's care. So swallowing evaluations, especially with many of our stroke patients, may be the first opportunity for someone to meet a speech therapist. There are several different kinds of swallowing evaluations that may take place. That can be done if you're in the hospital at bedside. It may be done in a clinic. It may be an X-ray of the swallow called a video swallow, or even a fiber optic endoscopic evaluation of swallowing, which is a FEES. So I wanted to put that out there, as well as the speech language evaluation that we will go into great detail over today. We also see patients who have cognitive issues. And when we're finished today, you will be able to determine which is speech and language deficits or aphasia and which are cognitive deficits, because we'll talk about that, as well as a true motor speech evaluation. So when there are changes in that speech function and how those words and sounds come out of the mouth, what that looks like. If someone has a trach, they may need a speaking valve evaluation, because as speech therapists, we want you talking, we want you communicating, as does your nurse or physician or family member. So a speaking valve evaluation is something that may be completed with a patient, as well as an augmentative communication evaluation, meaning a different type of device may be used to help in the role of communication. So that's just kind of an overview. It may be like way too much information, but I wanted to make sure that we kind of touched on those because we may during this presentation as well. So a speech therapist could be located in many different areas. Generally, we fall under the rehab medicine title because it's part of rehabilitation after a stroke or a brain injury or many other neurological things. You may find a speech therapist in-house on an inpatient unit or in the ICU. It may be at a rehab facility, an outpatient like I am right now. It also could be home health. Having speech therapy at home, to me, is so functional because you're right there at home. That's one thing I really like about the telehealth that we're doing right now, is we get to see people in their homes, and that's very functional. And then private practice as well are other locations that you might find a speech therapist. Today's focus is going to be on aphasia, and aphasia is an acquired loss of language, making it difficult for someone to speak, to understand, to read, or to write. So that may be from a stroke. It may also be from a brain injury or a tumor, something in that left area of the brain that we'll talk about even in greater detail as we go through the morning, and how it looks different for everyone. That's the one great thing about that brain of ours is, as you know, what is located in general in the area of the brain might differ a little bit. And so someone with a stroke, as you know, may look very different than another person with stroke. Someone with aphasia may look very different from someone else with aphasia. So we're going to break this down this morning, starting with an anatomy lesson. So there's that lovely brain of ours and the different lobes and kind of how it sits in that brain. We're going to go over each of these sessions or sections of the brain. It's bad when your speech therapist can't talk, so hang in there with me. Then we're going to be able to talk about what each of those lobes and the importance of those lobes. So we're going to start with that. And I tried to do some handouts and some things that we could get access to you easily. So if you want to go to some of the references or some of the websites we'll talk about today, you can even print these out if you'd like. And Constant Therapy is a corporation that have a bunch of different materials for us as therapists to be able to use, and materials for patients and family members and caregivers to be able to use as educational tools. And I love this one because it really breaks it down, like the color coding of it, but it talks about what happens in each of those lobes. So that frontal lobe there in pink, obviously it's not pink in our brains, but it's involved in a wide range of higher level cognitive things. And we're going to look at right side of the brain versus left side of the brain as well today, because that left side of the brain is generally the place where I would say is high real estate in the language in the aphasia area. But that frontal lobe, you're going to be able to, it's involved in, I should say, a lot of functions such as attention, reasoning, decision-making, planning, performance, kind of some problem solving, and then how things move motorically. That might be any part of our body, as well as even our mouths and how our mouths, our lips, our tongues move. The temporal lobe is responsible for the understanding and processing of language, sound processing, some memory, whether it's on the right side or the left side of the brain, and then even facial recognition, which makes it interesting. That parietal lobe, and I kind of like to think of it as moving back. So we're starting here with the frontal, and then we're moving to the temporal and the parietal and the occipital. This is a hard thing about doing this virtually, because I would be using my hands a lot and we would be looking at that brain differently. But the parietal lobe, really think about sensory and our senses, and then where things are in space, but also our math and writing skills, which is part of our language. And then the occipital lobe. So as we move back, that visual and depth perception and kind of looking at color and where things are in space is going to come from that occipital lobe. If we go lower, so kind of down that brain to the cerebellum, that's where a lot of coordination is, and how we balance ourselves and stay upright, that our muscle tone. And then finally, as the brainstem, as it moves into our spinal cord, this regulates the basic functions such as breathing, heart rate, sleep, and especially swallowing. So for me, that's an area with the swallowing and even with our speech that is very important in that brainstem. So left versus right. When I think language and I think language impairment from resulting in aphasia, I think left side of the brain. We teach our students, we teach all of our, anyone who comes to observe us, we're looking at what does that left side of the brain do compared to the right side of the brain. And the left side, as you can see in this handout, and this is another one that you can print out if you'd like, but speaking, reading, writing, listening, our grammar, our spelling, how we work with numbers and how we reason through things. And then it's important to think about the left side of the brain controls the right side of the body and vice versa. So the right side involves the left side, which is a question I always have. If you have someone who has aphasia and they have either trouble getting words out, understanding words, reading or writing, I think it's just crazy to think that if you think about, most of us are right-handed. And so that writing can be impaired neurologically from the brain, but our hand is impaired too, which is crazy. And so it makes it hard motorically to be able to write, but also just being able to think about what you're writing and be able to write it. So that's the lovely left side of the brain. As we move over to the right side of the brain, we look more at our behaviors and what we call executive functioning, which means, hey, I know I have to take the trash out and these are the steps I have to do. And sometimes people will be like, you're just being lazy, not taking out the trash. No, it's my executive function is impaired. I know I need to do something It might even be turning on the TV, but I can't go through the steps to be able to do that because that right side of the brain is injured and executive functioning isn't working like it should. The right side of the brain is also very important for our visual information. Again, that facial recognition, kind of our emotions. If we fly off the handle or we cry easy or we don't. It may even be if you have the flat affect. So a monotone voice comes from that right side impairment. And then art and music awareness. And then again, that left side of the brain, it's going to control the right side of the body. So you can see where both sides of that brain are doing different things. So if there is a stroke or an injury to one side of the brain, different things are going to be involved. So that's where that no two strokes are really going to look alike. And when they do, there's personal things that may look a little bit different for each person. So kind of gives you an idea of left side and right side. So let's talk about aphasia. Let's talk about language impairment. You can see at the top of this one, loss of language. So you lose that ability either to get words out, to understand words, to read, or to write. And a big one is this is not your intelligence. And I tell people that all the time. Just because you can't say the things you want or understand like you could before, it's not your intelligence. Your intelligence is on the other side. And so your language is what? You're still just as smart as ever, smarter even, because you've got to find other ways to be able to communicate. And that's very tricky for some people sometimes. So you can see in this little model of the brain what those two kind of primary areas, and we're going to go into those different areas a little bit in greater detail, but where the speech comes out and where our understanding is in our brains. So sometimes you may hear it as expressive aphasia. And if that's the case, that area, that Brokaw's area, that pink that you're able to see there is around that area may be more impaired versus the understanding or receptive aphasia. And that is someone's inability to understand what's being said to them. So I had a patient this morning and she was telling me, I went on a trip by myself. This is her first trip by herself. She said, I was great until I got to the hotel. When I got to the hotel, the lady just started telling me all of this stuff and it was overwhelming to me. And some of you may feel like that listening to me. But and you could hear it, she probably checked in and the lady said, okay, you're going to go to room 203. That's right around here. You're going to take this elevator up. Breakfast starts at 7. You can, if you need an ice machine, it's here. If you want to park your car, it's over here. And it was just overwhelming to her because that auditory comprehension or that receptive aphasia that she had. So it kind of gives you an idea of the two different kind of a visual for you. Interestingly, over 2 million people in the United States have aphasia. I have a statistic here that says about 25 to 40% of stroke survivors acquire aphasia, which is, that's a big number of our stroke patients. 180,000 Americans acquire aphasia every year, and it affects patients of all ages. And we have patients from, I think the youngest that we've seen and treated or that I have has been 11. We know it, at Children's Hospital, I'm sure they see younger than that. But our cutoff has been kind of about 11 years old. And depending on the type of stroke that it is, that first 6 months as a speech therapist, I want in someone's face because I want to be working. But I always tell people, let's say it takes 3 weeks to get into speech therapy. You are still doing therapy because you are communicating all the time. You're listening to what people are saying. You're understanding what people are saying. You're talking, you're communicating. So you're doing therapy yourself. And so that first 6 months is important. For some, depending on the type of stroke, it might be that second 6 months. But when I first started, we said, within the first year, if you didn't have it, you weren't going to get it back. And then it said the research changed and it said within the first 3 years. And now studies show you can continue to make progress 10 years beyond when that stroke may be. So that I feel like that's an important, you are always communicating and improving. So treatment, it's interesting because, we talked about all the locations where a speech therapist may be. So it may be in the hospital, it may be as an outpatient, it may be in a rehab facility, it may be at home or private practice. And I didn't mention telehealth. And so lots of people especially during this pandemic, have changed to getting their therapy on telehealth. And as speech therapists, we've learned to be able to do that in different ways over telehealth too, which is kind of fun. I like that part. So again, down below in the pink, you'll see because of the brain's plasticity or neuroplasticity, there's no end to recovery. And so just knowing, hey, you're constantly communicating and improving. I love, and part of the reason I wanted you to have this was the people who are on the bottom of this. So you can put your face on there too. But Randy Travis and Gabby Giffords, you can see all of those people, Dick Clark. Another one I thought of, so the National Aphasia Association send, I think it's about every day, if not every week, we get emails from them. And I was reminded by their email today that on the Waltons, if you watched the Waltons growing up like I did, grandma had aphasia. And so she'd had a stroke. And on that show, she didn't communicate very much at all. But I had forgotten that until seeing that this morning, that they even wrote it into their storyline. So I love that. And I love all these examples of people with aphasia. So we've talked a little bit already about what a speech language evaluation is going to look at, the auditory comprehension or understanding someone has, how they're getting words out, reading and writing. And that's generally if the person is right-handed and they are left dominant for language. There are people who may be left-handed and they might be right dominant, or they might be left-handed. And most of those people are still going to be left dominant for language. But sometimes you get someone who is right-handed. I think of a motorcycle rider that I had, and he could not get more than 3 words out at a time. He was right-handed, but he had to have been left dominant because his aphasia was so severe that he couldn't get long sentences out. He didn't understand people well. And but he was very functional. We think that he remembers as a child he was left-handed, and his parents and teachers made him learn to write right-handed, and so he was probably right dominant for language, and he probably was using not his dominant hand either. So that's a little much probably on the dominance of where our language is, but kind of gives you an idea of our hand preference too. So we talked a little bit in detail about what areas of the brain. I like this because it kind of highlights exactly what that color did. And it talks about what we see in each of those lobes. I don't want to duplicate it, but it kind of gives you another idea of what's happening in each of those lobes. And depending upon where someone's stroke is, so if it's in the frontal lobe, right side or left side, that's when you're going to think, okay, as a speech therapist, I know you had a stroke on the left side of your brain and it was in the frontal lobe. These are the tests I'm going to take, or these are the things that I'm expecting to maybe not work as well, so that I can look at those in greater detail. So I can use a test to be able to look at those in a little bit greater detail. And so this shows, okay, if this is, let's say, a stroke in that frontal lobe, then I'm going to expect to see that paralysis most likely on one side of the body, might even be in the face, not just arm and leg, but it's going to be difficult for someone to focus on a task. You may see that irritability, like we talked about on the right side earlier, changes in behavior, personality, or changes with problem solving if it's on that right side, or it could be language. So it kind of gives you an idea of, here's what the brain does on this side. Here's what I'm looking for if it's injured. And then the parietal lobe. And again, you can see where that green is and what I'm going to be expecting. Oh, can they distinguish right from left? So you might have someone ask, I want you to touch your right ear or your left elbow, or I want you to touch your right ear with your left hand. And so being able to see that left-right discrimination is really important, especially if you're driving. Turn right at the corner. Well, if you don't know right from left, that's going to make it pretty hard. But that parietal lobe is also going to really look at kind of hand-eye coordination, reading, writing, naming, so beyond just that talking piece of things, but parts of our language. Then finally, and you can see in this green where that temporal lobe is, and kind of think about where that is in the brain, and what do I expect there? Well, okay, it's going to, I'm moving back through the brain, and I might have trouble getting words out. I might have trouble recognizing people. I might have trouble naming things, coming up with the words that I want to use, as well as different behavioral changes too. So that's going to kind of work back through there. Very back of the brain, the occipital lobe is that vision. And I think vision, and you think, how's it going to affect writing? How's that going to affect reading if my vision isn't where it should be or doing what it should be? So that kind of works your way back through the brain, not only as a therapist going, what am I going to be looking for? Because you don't really want to, I want to know which test to use or what to I would be looking for during an evaluation, but also kind of those expectations, and then to be able to explain to family what's going on with those. As we move down through that brain, and we talked about earlier what that cerebellum and that kind of that squiggly part that's there, and then the brain stem, how those play a role, some of those deeper structures in our brain. So that kind of works your way through that. But from an evaluation standpoint, so let's get to the heart of the matter, and how does this work? And a speech language evaluation might be done in the hospital, in the bed. It might be done, sitting in a clinic. It could be done at home. And I included our cute guy on telehealth as well, because that's a really very real part of our lives. But what are we going to look at? So let's say I have a patient and I know they had a left-sided stroke, or a left MCA, meaning that cerebral artery that's in there. So I know those are my high areas of language, and I want to be able to look at that. Well, I'm going to look at what does their verbal expression look like? And that might entail having someone do some automatic speech, which would be things like counting, days of the week, months of the year, alphabet. It might even be singing. So many times if someone has had a stroke and they're nonverbal and there are no words coming out, those automatic things are the things that may be able to come out easiest first. So being able to sing sometimes is what helps get the words out. And it might be a hymn, it might be happy birthday, it might be just a song that's almost automatic that we've known since we were very young. So we're going to look at how does that automatic speech come out, but then we're also going to look at how are you able to describe a picture. Many of you may have seen the picture of the mom standing at the sink, and the sink is overflowing. We wish we'd get a new picture, but it's very purposeful. Of course, the kids are falling, the son is falling off of the stool, and that stool, he was trying to get cookies out of the cookie jar, and the sister has an ornery look on her face, and she's giggling at him as he's doing that, but he's about to fall. And but it's a hand-drawn picture, not a real picture, to make it even more difficult. And so there are opportunities in that for getting out sentences, for naming things, for being able to see, are you visually able to look at that whole thing, or is only half of it coming up? And so that's a very popular picture that many people after a stroke have seen, or even not after a stroke have seen. But we're looking at how are those words coming out? Are they full sentences? Is it maybe one word at a time? Maybe up to 3 words at a time? Or is it long sentences? Long sentences that don't make sense can also happen. So that's looking at the verbal expression in our testing. We also look at auditory comprehension. So how is someone understanding? When we do that, we may start with having someone repeat words and then repeat sentences, follow directions, answering yes/no questions, answering questions about a short paragraph, all to be able to see, are you understanding what's being said to you? If that's easy, moving it up to higher, just like the hotel example that we talked about earlier, being able to say, if I'm in a real life situation, am I able to understand the directions that someone's giving me? The third thing that we would look at is reading. Are you able to read at the word level, then at the sentence level, and then at the paragraph level? Same thing for writing. Are you able to write your name? Can you write numbers? Can you write a word? Can you write sentences? Could you write a thank you note or a paragraph about yourself? So those are different ways we look at writing. Vision plays a big role, as does, being able to move that hand like we talked about earlier. Depending on where that stroke was, sometimes you don't have the full visual field that you used to have. I had a patient who I went into his room. He had eaten only things on half of his plate, and he'd shaved that morning, and he only shaved half of his face. So he's probably one of my favorites ever, because it's just amazing, because he didn't know he had to cross midline to be able to look and be able to scan that entire area. So depending upon where that stroke is another reason why we need to know what we're looking for. So that kind of gives you an idea of what we're looking for, even within the evaluation. Many times, if someone's verbal expression is impaired, their writing is going to be impaired. So if it's hard to be able to talk, it's going to be hard to be able to write, because they're both expression. If it's hard to be able to understand what people are saying, then it's most likely going to be hard for people to read. Not always, but there are most situations where those kind of parallel each other: verbal expression and writing, auditory comprehension, and reading. So that gives us areas where we know, hey, I need you talking before I can get you writing, but those are always out there for us to work on. There are different types of aphasia, and this is a hot topic, and I know this is one of the questions that some had for today. Are the types of aphasia? Why does it look different? How do we determine which type of aphasia we have? We're just going to kind of talk about a couple of those. This is a really busy diagram, but we've already kind of touched on a few of these, and we're just going to touch on a couple at the bottom of this. So if I know someone has had a stroke on that left side of the brain, or an injury to that left side of the brain, I want to determine what type of aphasia it is. And the reason we want to do that is so that we know, okay, what goals are we going to work on? How are we going to work on this? What's the easiest thing to be able to work on? And then we also know, hey, this type of aphasia is a little bit easier to work on with these different strategies compared to a different type of aphasia. So the first thing we do in that evaluation that we just talked about is look to see, are you fluent or non-fluent? And what that means is, how long are your sentences? Are you able to only get a few words out at a time, which would make you non-fluent? Or are you able to just ramble on like I'm doing right now? And so getting long sentences out. So then that breaks down to, how are you understanding? So you might be able to talk up a storm, but you're not understanding anything. Or you may not be able to talk at all, but you're understanding everything someone's saying, or most things someone's saying around you. And we always want to assume that, but we also need to make sure that if I'm talking to you like I am right now, you're getting everything that's being said. So we're going to break it down from non-fluent to fluent, and let's just go one direction. So we're going to go the non-fluent direction right now. So I'm only getting a few words out. I am not understanding what people are saying, and that means I'm not answering yes/no questions, or I'm not following commands like I should. And then the repetition, where I earlier said I'm going to have someone repeat words for me. So I might have them repeat car, table, chair, bed. They do that fine. Okay, so they're doing well with repetition. I'm going to increase the complexity of it. I'm going to have them say a sentence. Please sit down. And then they get longer and longer to, I ordered a ham sandwich with a glass of milk and a piece of apple pie, is another one that we use. And if someone can't say that, then we know that the repetition isn't good. So if we're going along and we know that someone's non-fluent, we know they're not understanding what people are saying to them, and they can't repeat, then they're going to be what we consider global aphasia, meaning they're not understanding and they're not getting things out very well. So we have a lot to work on, and we start with the basic things. The opposite of that on the non-fluent side would be somebody who their comprehension is good. So they aren't getting words out, but they're understanding everything that's being said. And so their comprehension is good. And let's say now they can repeat things. And actually, I'm going to switch it. I'm going to say we can't repeat. So can't get those words out because that mouth isn't moving like it should. It's not doing motorically what it should. And so there may be what you see on there as a Broca's aphasia. So global aphasia is one, and Broca's aphasia is kind of the opposite of those people who can't get much out. Those are the two most common on that side of the diagram. So now we're going to switch gears. I know this is a lot of information, into people who can get words out, sentences out even. And their sentences might be 5 words, 7 words, might be 12 words long. And so if they're able to, again, understand, let's say they're not able to understand what's being said to them. So they're talking up a storm, but they're not understanding anything you say, and they can't repeat things because they can't really follow those directions or understand. Then that's going to be what we call a Wernicke's aphasia, that W down there. And that is, it means they can talk and they look fine, but boy, they're not understanding and they are not getting things out well. So that's going to be one side of the fluent. So they're talking up the storm. Let's go to the other side of that. We're going to clear down to the end, and they're to an anomic aphasic. And that means they're able to get everything out. They can understand everything someone's saying. They can repeat things really well, but they cannot get words out. And so they can't get, if I'm trying to think of an orange, it's a fruit, you have to peel it. It's orange in color. And so coming up with words, anomia means a word finding problem. And so we have to work on how do we get those words out, get them out quickly when you're in a sentence, and be able to really feel like those words are coming out fluently. So that kind of breaks down about 4 of those most common different types of aphasia. Can someone fit in several or in none of them? Absolutely. There are many times we will say consistent with a Broca's aphasia or not consistent with any, but we still have goals and we still know where the breakdown is. So that's how we know what to work on in therapy. This is just a different kind of lot less busy way of looking at it, but you can kind of see here how types of aphasia is the person fluent, meaning those long sentences, are they understanding and are they repeating? So that's kind of how we break those down too. I just thought it was a lot less busy and prettier. So this is kind of a cheat sheet. It's what we just went through. If I know that top one is a good example, someone has Broca's aphasia, it's going to be hard for them to get speech out. It's going to be hard for them to repeat words, but they're understanding, but they might not be able to get those words out. So this kind of is a cheat sheet for speech therapists to be able to say, hey, if I have someone who is fluent, but yet they can't understand, what type of aphasia could that be, and help to categorize that. And finally, I wanted to reiterate the fact that aphasia is the loss of language from that left side of the brain. It's not intellect. And I think I even have it on my cabinet because many times I have to pull that magnet off to be a reminder of, hey, you're just as smart. It's that language that's impaired. I want to talk a little bit about motor speech and getting those words out. So sometimes those words come out, but they may be slurred, and it might not be either slurred or imprecise, or the consonants aren't quite right, or it's not fluid when it comes out, or it feels more spastic when it comes out. Those are types of dysarthria, meaning a motor speech disorder. And slurred speech is usually the easiest way to describe that. That's different from an apraxia. Earlier, we talked about Broca's aphasia, and apraxia is more of a motor planning problem. So someone knows what they want to say, but between their brain and their mouth, the signal gets crossed and they can't get it out. So that would be a verbal apraxia that you see with patients. And it might be that they kind of have a groping. Oh, I know that I want to get that word out, but it doesn't work right. You can also have an oral apraxia just with the mouth, meaning, okay, I'm going to have you smile for me, and it feels like it just won't work. You can't control it. I want you to do something like try to whistle, and they stick their tongue out instead, or they can't round those lips. Those lips, the tongue, the mouth just doesn't want to work like the person thinks it should. And that's a motor planning problem that sometimes we see, especially when that left side of the brain and the frontal part of that brain is involved. That's a motor planning problem called apraxia. It can also be in limbs too. So it might be with the hand or the leg as well. I wanted to include different ways we help communicate when people can't get words out for various reasons, whether it's aphasia or it may be other speech problems. So you might see a letter board or a picture board that someone has to use or point to. If they're able to do that accurately, that may help with their communication. A whiteboard, which, just as we talked about earlier, whiteboard's great if you can write, but many times if you're having trouble getting words out, it's hard to write it as well. For some, it works just fine, but not always. So, and then also a computer device. Sometimes we will use different computer devices to be able to help people communicate, especially if we know, it's working, the brain's working and it's making those sentences or those words, that communication, but it's not coming out. And they can do that by looking at a computer and being able to point to pictures or put sentences together that way. So what do we do? How do we help someone? We talked about how we evaluate them. We kind of talked a little bit about what it looks like in therapy and how we break things down and start at the beginning and work our way up. But as someone with aphasia, what are the things we tell them? Well, we want them to, I always say relax, and that's easy for us to say when our speech is fine, but relaxing many times will help people to get the right words out and help keep you calm. Keep it simple, be patient. Remove the distraction. So today, if my door was open and my phone was ringing and my cell phone was going, it's really hard to stay focused, especially if the words don't want to come out. And so that environment is really important. And then keeping it simple so that they can communicate, or you can communicate as effectively as possible. But what about the person who is helping? How do we help you? Well, we want to do those same things to be able to allow you to have time to help you get the words when you want help, and just being patient to be able to listen and communicate effectively. Communication cards is a huge one for me. I feel like, and I always explain to people, especially if they're driving, but not even if they're driving, if they're just going to be at home, and let's say something happens to their caregiver, or let's say they're driving and someone hits them. Not your fault. We know you know how to drive. Or if you're just at home and something happens, as someone who has a brain injury or has had a stroke, as you're tired and when you're fatigued, when you're stressed or upset, many times it's even harder to get words out or to understand things. So I always say, I don't want someone to get stopped by the police and then the police officer or fire or whoever comes, EMS, to help. We don't want them to think, oh my goodness, this person's having a stroke, or this person's being belligerent, or they're uncooperative, or something's happened and their brain has changed. And no, this is the baseline. And I want them to be able to have a card with them that says, hey, I have aphasia. I have trouble talking. Here's how you can help me. I just feel like that is very important to have in a wallet, in the car, at home, so that if something would happen, maybe that comes from the fact that I have a son who's a EMS and firefighter, and I think, oh my goodness, if he came to one of my patients, I would want him to know what to do, and I would want my patient to be able to provide him with, hey, this isn't something new, this is me, and this is what I need from you right now in this emergency situation when I'm upset. So there's my spiel on communication cards and the importance of them. I want to close with another type of aphasia that you may hear about and see, and that's called primary progressive aphasia. I feel like we're seeing more and more patients with primary progressive aphasia, partly because we're figuring out how to diagnose it. And this is a type of aphasia, much like what we talked about earlier, because of different reason or different etiology, meaning it's not from a stroke, it's not from a tumor. It's most likely from a sort of dementia where the brain, the language area is affected, and there's a loss of language because of that. So that's another type of aphasia, very different from a stroke or a tumor or brain injury, but it's a type that over time progressively changes the language, and you end up with a primary progressive aphasia. So I wanted to be able to add that. I know that's not as relevant today, but I feel like that needs to be a piece that's addressed as well. So the other thing I wanted to make sure of is we've talked all about left side of the brain. And if someone came in and there's a stroke on the right side of the brain, we know they're not language dominant on the right side of the brain, then these are the areas that we would look at in a different type of evaluation, which would be that executive functioning. What's their behavior look like? How's their attention and their memory? Memory is a hard one because many times someone with a stroke or with aphasia, they'll say, oh, I'm having memory problems. Well, I always explain it as, you're not having memory problems. The information just isn't getting in correctly. So think of it like a filter. The information comes in. If there's language impairment there, I describe it like a colander at the beach, and you go to the beach and you have this colander and you put all this sand and stuff in it and you pick it up, and most of the sand gets through, but there are chunks of information or chunks of shells and rocks and things in the sand that don't get through. And that's kind of like our understanding. So you have someone who can get most of the information in, but there are bits and pieces of it that don't quite make sense, like the lady at the hotel. And so most of it's there, but you can't get it. Well, then many times that looks like the person has a memory problem. Well, it's not a memory problem because it can't get in. And it's not a memory problem if you can't come up with a word, because it's a language area that problem versus a true memory problem that's a little bit different on that right side of the brain. So those are just the areas that we look at if there's a right-sided stroke, different from that left-sided stroke. And that is about it. So I know I've rambled a lot of information and thrown a lot of information at you. So I want you to be able to, you're welcome to turn on your mic and ask any questions that you might have. I'm happy to answer those. So